So another issue to remember is ischemic stroke mechanisms. And if you look at the next slide, it actually shows this mechanism. So as you can see, large vessel atherothrombotic stroke accounts for average about 20% of these patients. And there may be patients with cardioembolic mechanism, lacunar stroke mechanism, other mechanisms, and then undetermined up to 30% in early studies. Now, with more considerable workup, besides admission CAT scan, besides just carotid duplex, if you deploy MRI, if you deploy carotid ultrasound, TCD, and cardiac workup, you may reduce the number of undetermined or cryptogenic strokes down maybe 15 or even 10%. You would never reduce it to zero, but you can substantially reduce that number of stroke patients. But again, the message is, do not look just at the neck for this proximal ICA as the source of all the answers in stroke patient workup. The next slide shows actually a diagram of the circle of Willis with projection of the spectral waveforms out of the circle of Willis. And this is original approach with transcranial Doppler as defined by Rooney Aslett. In fact, it's his drawing right there. And for a long time, we had simple single-gate spectral waveform analysis that was very unobvious to sonographers because there was no image attached, and it required a long time to acquire skill and ability to navigate through the circle of Willis by just switching the depth and putting together in your head these spectral waveforms. As technology evolves, now more centers have transcranial duplex ultrasound, and whenever I say TCD, same comment applies to transcranial duplex, because you can combine carotid duplex examination with transcranial duplex examination and do a considerable imaging study of the cerebral circulation. The bottom right part of the image is the power motion Doppler that expands capabilities of TCD in detecting and localizing the signals. If you look at the next slide, it shows normal waveforms in the middle cerebral and anterior cerebral arteries in an asymptomatic 32-year-old man with normal blood pressure values. As you can see, there is sharp systolic upstroke, there is good diastolic runoff, and there is a bidirectional signal where both vessels have low resistance flows. Now, if you advance to the next slide, you will see a 67-year-old man with a recent TIA and severe ICA stenosis, and you see how these waveforms obtained at similar locations change. Middle cerebral artery, distal to the stenosis, becomes what's called blunted, or delayed systolic flow acceleration, flattened waveform because of compensatory vasodilation, and because the flow had to pass through narrow collateral channels that are not yet developed, or pass through a significant narrowing to get to the point. And the waveform below shows a very high velocity jet with diastolic velocity approaching 190 centimeters per second. This is a part of a partial arterial cross-filling in that particular patient. So as you can see, looking at downstream changes to the ICA on transcranial Doppler can reveal some of the striking findings that will help grade severity of the internal carotid artery involvement. So next slide shows one of the papers on this subject, downstream TCD findings. Our group published what was an improved broad diagnostic battery from previous works, where we put together typical findings that one can anticipate on transcranial Doppler if there is a major carotid stenosis or occlusion. So the next slide details major criteria such as collaterals, abnormal MCA waveforms, delayed systolic acceleration, and minor criteria such as decreased MCA pulsatility, some presence of flow diversion, or compensatory velocity increases. If you apply these criteria like we did, and the next slide shows the table where percent stenosis was graded by NASET criteria from normal to occlusion, and percentage of abnormal TCD findings, As you can see, when the stenosis becomes severe, 70% to occlusion, the percentage of abnormal TCD findings raises dramatically, and that information is useful to actually confirm or rule out hemodynamic presence of hemodynamic significance of the ICA lesion. That's number one. Number two, it helps refine some of the carotid duplex examinations. For example, if one presents with false positive carotid duplex study doing TCD and finding that carotid duplex said 90% but TCD is normal, surely will raise the question how accurate was that carotid duplex examination. So that's number one. Number two, if someone presents with normal carotid duplex examination, seeing abnormal TCD with these findings, would question, was there a lesion missed, or is there a lesion at the entrance to the skull, for example? And that's how quite often we find intracranial lesions or dissections and so on. Next slide is called How to Identify a High-Risk Plaque. Well, high-risk plaque may be identified as hypoechoic, predominantly occluscent on B mode, or the one with irregular surface on B mode and possible ulceration as a combination of color flow and B mode on carotid ultrasound. But it may also be identified through additional test on TCD. And the three parameters that I look for is either emboli, spontaneous emboli on transcranial Doppler distal to the plaque. Is there delayed systolic flow acceleration or the blunted signal that would imply incompleteness of circle of Willis and suboptimal collaterals? And what is the vasomotor activity on TCD? Is it impaired? Are the vessels already maximally dilated and they cannot accommodate for any more narrowing of that particular vessel? And here is an example. Next slide shows a duplex image with a color-coded insert of a mild plaque. It basically caused no more than 30% stenosis, no velocity elevation, but it had an ulcerated crater. In fact, the image belongs to Dr. Charles Tegler and Dizzy Ratanakorn out of Wake Forest University Laboratory in Winston-Salem. And the lesion like this can confuse everyone, because by percent diameter reduction, it doesn't reach severity of NACET trial. In fact, it may not be even on the scale. But in a young person, a plaque like this, particularly with recurrent symptoms while on best antiplatelet medication, may necessitate some intervention and surgery if one can demonstrate the presence of emboli, and that indeed was the case in this particular situation. So here is an example of data. Next slide, on embolic plaque burden. This is an example of data that was obtained prospectively by Hugh Marcus Group out of London in England. And here is 111 patients with greater than 60% stenosis. 69 of them were symptomatic, 42 asymptomatic. Embolic signals were detected in 37% of these. And if TCD study, on top of carotid ultrasound, if TCD study was showing emboli for the same percent stenosis, the risk was 8-fold higher for first ever or second stroke occurrence. Next slide is also showing some vasomotor activity data. This is on asymptomatic greater than 70% stenosis. This is the study done by Italian group of Mauro Silvestrini, published in JAMA. In fact, one of the papers that actually led to acceptance of vasomotor activity testing as part of routine and reimbursable practices in the United States. Here is the overall risk of any ischemic stroke, 7.9% per observation year in the study. If breath holding index was normal, risk recurrence was lower than average, and if breath holding index showed impaired response to holding breath, then risk of stroke was increasing more than 3-fold for the same degree of asymptomatic stenosis. And the formula how to calculate the test is there. I don't have time to go into details. You can look it up. The methodology of this has been published. Even though it's not the best test to assess vasomotor activity, If you don't have any dedicated or specifically validated equipment, I think majority of patients can do reasonable job tolerating and cooperating during the test, and you may get some useful information out of it. And the same breath holding index value has been replicated with patients with carotid occlusion, where if you have 2 collaterals, your risk of stroke is least, as defined by TCD. 1 collateral, you go high on risk of stroke, but if you have impaired vasomotor reactivity on top of that, that's the highest risk of stroke recurrence distal to carotid artery occlusion. So for my final slide shows combined use of carotid duplex ultrasound and TCD as it's shown here. When do we use it? Well, in our institution, when one evaluates a stroke patient, acute, subacute, chronic, or a TIA patient, both tests are ordered at the same time. And in fact, majority of our patients have CAT scan on admission, CT scan on admission, non-contrast, followed by MRI within 24, 48 hours of admission, and carotid duplex and TCD done in the emergency room if the patients were acute, or on the floor if they were subacute. But all of these tests would be front-loaded and done on the first day or 2 of patient stay, so we can get to the pathogenic mechanism, we can identify the offending mechanism of stroke, and tailor-made our secondary prevention strategies and treatments. So particularly remember when to order both carotid and TCD if you don't do it routinely. If you didn't see the distal end of the ICA lesion on duplex ultrasound, you didn't see the end, you may be missing the most significant portion of the stenosis. So ICA lesions extending beyond direct incination field. If you have tandem or bilateral lesions, if you want to identify high-risk plaque or occlusions at high risk of stroke recurrence, remember that I mentioned only screening for intracranial disease and other stroke mechanisms. This is becoming more and more important field. And the last but not least, you can use transcranial Doppler for monitoring thrombolysis. This is a rapidly developing area in the stroke treatment arena, and I'm looking forward to update you on the progress on this in the future. Thank you.